steered, so it's come out of the joint, so directly the force is transmitted to the cartilage as well as the bone. That is the reason why pain is so much common in these patients. So if we talk about the treatment of these patients, so first of all we have to identify कि why this patient got this problem. So these are the patients, जैसे आपने first thing आपने बताया, they are under over stress. And because of the aging, there are some degenerative changes in the meniscus. So that is the reason, because they are giving so much stress over these knees. So at the age of 45 or 50, they got meniscus tear. Second thing, ki when we evaluate those patients, they have varus alignment. And because of the varus alignment, the stress is transferred through the medial joint mainly. And we can say approximately 70 to 80% of the weight is actually transferred from the medial surface. So these are two reasons which are more common because for this problem. And if you talk about the treatment, first important thing is actually unloading. If we are able to unload the joint, the patient get better. So unloading can be done either by rest, or we can give them some special braces. Special braces means जिसमें middle compartment को open करते हैं. Third thing is making those muscles strong so that the alignment, or we can say the joint reaction force, can be minimized. And fourth one is correction of that alignment and repair of those meniscus. So ideal treatment in those cases are actually repair of that meniscus tear along with alignment correction. If you do only meniscus repair in those kind of the cases, they again fail, because the kind of meniscus which God have given them, it failed. So after repair, that meniscus cannot be healed like a natural meniscus. So we have to reduce the forces. That can be done by alignment correction surgery. And after that, we have seen so many patients, they are more than happy. Even in grade 3 arthritis with medial meniscus root tear, this high table osteotomy and meniscus repair works very well.
So I am taking the shoulder pathologies. So do you guys have any particular question in your mind regarding shoulder problems, or should I start from my own? Ketan sir, आप कुछ start करना चाहिए?
My only question was, is there any after post surgery for any ligament for knee? So I have seen some surgeons telling to go to a physio after 15 days. Some surgeons say go the next day itself. So would there be a protocol among the orthopedics to fix a thing ki baba after so and so surgery, baba within this amount of time you go to a physio?
Okay, so for me the physiotherapy starts from the day of surgery, and it would vary of what kind of physiotherapy I would be suggesting. So initially the bed exercises would be there, the static exercises, then range of motion exercises, maybe then later part we can put on to them some weight bearing and other exercises. So there are various stages on which I put my patients on. So but physiotherapy is a part and parcel of my treatment protocol, and it starts from day one till about 2 to 3 months till the patient is perfectly all right. Because I believe that I am incomplete, just like the theme for today is uniting for health. तो योगा आप जानते हैं ना, योगा क्या होता है? योगा इज़ द यूनियन ऑफ बॉडी एंड माइंड. तो मेरे लिए मेरे पेशेंट की हेल्थ केयर में एक योग है जिसके अंदर में कि जब तक मैं और मेरा फिजियोथेरेपिस्ट नहीं है, जब हम दोनों का यूनियन नहीं है, तब तक हम परफेक्ट रिजल्ट्स नहीं ऑब्टेन कर सकते. तो इसलिए मैं जब भी अपने पेशेंट्स को, इनफैक्ट आई सजेस्ट प्री ऑपरेटिव फिजियोथेरेपी एज वेल. ऑपरेशन से पहले भी अगर हम गुड रेंज ऑफ मोशन स्ट्रेंथ वगैरह ले सकें तो हमारे पोस्ट ऑपरेटिव रिजल्ट्स भी इंप्रूव होते हैं. तो इट्स डिपेंडिंग ऑन द स्टेज ऑफ द प्रोग्रेशन ऑफ the treatment that the protocols are set, and accordingly we guide our patients. So thank you. So friends, let's discuss a few things about the shoulder joint. Shoulder, as you know, is an inherently unstable joint, and there is a lot of mobility in the joint, but that comes at the cost of stability. Also, there are about 22 muscles around the joint that work in sync to give it the best working position, functional work. So shoulder joint is prone to various kind of injuries and various kind of muscle imbalances which causes this joint to be painful or unstable. Now, you may have come across a lot of these patients who dislocate their shoulders either due to sporting activities, injuries, or various other regions like electric shock, etc. And these patients usually, when they are come in the acute stage, they come to us because there has to be somebody to reduce these joints. But in the later stages, they usually avoid surgeries and they come to you more often. And the reason primarily is that they want to avoid the surgeries. But sometimes in the process of avoiding the surgeries, what they do is they dislocate multiple times, because of which there is significant bone loss. And in that scenario, it's the treatments become a little more demanding. So for patients who come to you for shoulder dislocation, they have multiple episodes of dislocation. My suggestion to you would be that eventually you are the people who are going to take care of the physiotherapy part of these patients. But when the patients come to you saying that they have sleep dislocations, they can voluntarily dislocate or relocate their shoulder joint, or there are more than 10 dislocations, then these are the patients that you should focus upon. सर शोल्डर जॉइंट्स की जो प्रॉब्लम्स आप लोग अपने क्लिनिक में देखते हैं, किस तरह के पेशेंट्स आपके पास आते हैं, एंड what kind of problems you encounter in your clinical practice that we can discuss on?
So basically, in our clinical practices, majority of our patients have adhesive caps, and due to sometimes it is affected with the diabetic shoulders also. Right. So if we run for example, if we run an MRI for a person who has been a teacher throughout his or her life, because of his or her teaching and writing on the board, we see that if we get an MRI done, we have always seen that the ranges are restricted. I mean, the overhead activities are restricted, and especially the rotations are restricted. So then when we run an MRI done, we have seen that commonly the supraspinatus injured is the maximum, especially tendinitis being the exact word. But sir, what we have seen that there's a particular tear also. Like if I would say ki, especially the reports have abundant with a word called Hill-Sachs tear. And if we see that there's some angulations, like it is between 2 to 6 o'clock, and it is between 6 to I think 9 o'clock. So these are particular patients which we see to the maximum level. Thank you for asking this question, sir. I would like to, for my personal thing also, I would like to ask you, sir, how is it the readings between the 2 to 6 o'clock and 6 to 9 o'clock, how are they important, and what care should we do and to take, and what is the criteria that, okay, itna phat gaya, there are partially tear shoulders, there is complete tear, there are complete tear shoulders but the patient does not have any pain, there are partial tears. In any adhesive caps, if we get an MRI done, there will be torn supraspinatus and there will be injured subscapularis also. So I would like you to, help me out ki kaun se angle mein, kaun se isme we have to send the patient to you in that particular shot, sir.
Okay, so I actually had a presentation for this particular program today, and that was based on this. But since you are having a discussion kind of a session, I'd like to tell that, the most common thing that comes to a clinician is adhesive capsulitis, of course. And there are various reasons for that. It is very common in diabetics, thyroid, Parkinson, post-trauma, immobilization, prolonged immobilization, and the rotational problems are, of course, there. First of all, these patients, you should not focus too much about these tendon injuries. Okay, the first thing is initially you should get a good range of motion. Don't read too much into MRIs, because MRIs, there is a lot of difference in the opinions of the radiologist also. So for me, I read my MRIs myself. I do not try to read the MRI reports at all. Or if at all I see the reports, it's only to see if I have missed anything that the radiologist may have picked up. So do not focus too much on the MRI. Our focus is to get the clinical range of motion and start strengthening exercises early, right? So once you get a good range of motion, so in my clinical practice, if I have 1,000 patients of adhesive capsulitis, 999 would be treated only by physiotherapy, and only one person may eventually be needing arthroscopic release. So first of all, these patients should be treated by range of motion exercises and capsular releases and all those things that you are best at. Once you get good range of motion, and also MRI at this stage is not useful. So once you have got good range of motion, then you again evaluate what is the problem with the patient now. Is he having weakness? Is he having night pain still? What could be the cause for that? And if on a repeat MRI on a good 3 Tesla machine with proper sections, if we feel that the cause of pain is one of these tears, then they have to be treated accordingly. Now tears can be of the muscles or tears can be of the soft tissue in the shoulder joint. Soft tissue in the shoulder joint would be the labrum, which is around the glenoid, and the long head of the biceps, which is an intra-articular structure. So it could be a lesion of the labrum, for example, the Bankart lesion, which causes the instability. Bankart's lesion is when the tear is from 3 to 5 o'clock, right? So that's the classical Bankart's lesion, which is associated with the IGHL avulsion. Now it could be associated with the complete tear, which can involve the inferior and posterior part or it could be one of the variants like the sleeve avulsion on the ulcer lesion, the GLAD lesion, the other things as well. So these are one aspect of these injuries associated with the instability of the shoulder. Anterior instability, Bankart, posterior instability, posterior capsular issues. Then the superior structures, which are most often neglected, these are the SLEP lesions, or the superior lesion from anterior to posterior. So from 10 to 2 o'clock, sometimes the superior labrum is torn. And these labral lesions are more often than not missed because there are not too many good clinical tests to identify these. So once you get a good MRI, then also you see the patient's profile and everything, and then you see if these SLAP lesion, what grade of SLAP lesion is that, and then accordingly we treat them. So we have to see if these labral lesions are actually the cause of pain. But primarily if the patient is having a rotator cuff tear, then and if the patient is elderly, then I would not too much bother about these labral lesions. I would be focusing myself more on the cuff. And also if there is any associated impingement along with it, that is between the greater tuberosity and the acromion, if the cuff muscles are getting impinged or getting in between them, and because of which there is some kind of a pain. So there can be a range of these issues. They can be simple tendinosis, that is inflammation of the muscle, or it could be tear. Now tears can be full thickness or partial thickness. Now most of these tears, they are bursal surface, right? And they are partial thickness tears. And most of these bursal surface tears, they do not need surgery. Article surface tears also can be treated without surgeries, but then there are those near full thickness tears, or they are symptomatic partial articular surface tears that may need surgical intervention. Also, there are full thickness rotator cuff tears that may not need surgery. So you have to actually